one of you guys, and the gas looks like this, 7.440. Is that normal? I know post-call is not, but normally, is that normal?
Yeah.
Yeah. But if I take Mr. X, who is barrel-chested, 50-year smoker, he's been smoking since he was 20, he's 70 years old, and he's a bad COPD, and that's his gas. Is that normal? It's not. So what is going on with him?
He's like blowing off too much CO2 now.
Great. So again, we don't believe that anybody lives in an abnormal pH, right? So we'll assume that he lives at 7.4, let's say 60. Okay? So he blew up more CO2. That what looks apparent to us that his PCO2 lower than normal. That's what caught our eyes, right? But if that's the only disorder that is happening, what would be his pH? His pH will be 7.56, because this is a change of 20, 0.08 per each 10, so that's 7.56. But it's not 7.56. Something brought it back to 7.4. So what is it? Metabolic acidosis. So this guy is having metabolic acidosis. So this guy is having 4 disorders. That's why there's pseudonormalization. He has chronic respiratory acidosis all his life that has been successfully compensated by chronic metabolic alkalosis. And then acutely, he's having acute respiratory alkalosis and acute metabolic acidosis. Which one do you think happened first? Most probably this happened first. So this happened first, this happened second, this happened third, and this is a compensation most of the time. Why? Because the patient could have a perforated bowel. Like he could come like here 7.440, has a perforated bowel, lactate is high, bicarb goes down, and he starts to compensate with respiratory alkalosis and pseudonormalize like this. Right? That's more common than the opposite. The opposite, you're not going to find it in the United States. You're going to find it in third world countries when people are not being, or maybe 10 years from now, when because we're doing in the swing now. It used to be the pain is the 5th vital sign. Now they're saying you don't give pain medicine for anybody. So if somebody's in severe pain for days, like he's crying in pain for days, he will have severe respiratory alkalosis, to the point that the kidney is going to say, how are we going to correct this alkalosis? We're going to lose the bicarb. So it loses bicarb and pseudonormalize. So it can happen both ways, but more commonly that the acute metabolic acidosis happens first and respiratory alkalosis compensated for it, right? But then you're going to tell me, come on, I'm not going to miss lactic acidosis. I mean, I know it's a cute thing to say, but we're not going to miss lactic acidosis. We're going to send the lactate, we're going to find the high lactate, for example, or we're going to find that the patient is having pain, or we do a CAT scan or something like this, and that will be easy to diagnose. Maybe, but what you're not going to remember to apply this rule for is renal failure. That's much more common than lactic acidosis. Why? Because COPDers, when I was young, COPDers lived till what? 70 years of age, 60 something, 70, barely made it to the 80s, because the medications were bad, there was no BiPAP, all of these things, right? Now, COPDers live to the 90s, hundreds sometimes, So if you reach to the late 80s and 90s, what happens to your kidney? You start losing the kidney function. And COPD and kidney failure, they don't mix. They don't like each other, right? Because the COPD is depending on the kidney to raise the bicarb. If you can't raise the bicarb, then it becomes a problem. So that patient in the ER can fool you so much, so I can give you the bicarb here just to imagine how easy to be fooled you are. 7.440, 24. Bicarb is 24, perfect. Like the book, right? But still this guy is in real trouble. So I'll give you an example. So I was in another hospital, and basically the patient comes in with COPD exacerbation. So, and he's wheezy. So we give him Solimedrol, put him on the BiPAP. He was easy to resolve. I mean, he was work of breathing high, and now he's comfortable. The next day, he's not wheezy, and we're talking, and he said, okay, I'm gonna get my trach. I agree now. I'm gonna have the trach. You know, in COPD patients sometimes they do a trach towards the end of their life. You know, just to give them a couple more years, because it loses the dead space. So anyway, so we're gonna get, he was offered the trach by his doctor, and he declined, and now he's gonna take the trach because he's been admitted a million times. You know, and especially in the last few months, a million times he got admitted to the hospital with COPD exacerbation, and he's tired of that. So I look at his gas, and then his gas looks similar to this. I'm like scratching my head. This guy is 70 years old. He has COPD for like 40 years. His kidney didn't even like raise the bicarb a little bit, just a tiny bit, raise the bicarb. It couldn't, all of those years. It's impossible, right? Something is happening here. So we looked at his historic bicarb, and you can see 3 years ago his bicarb was 40. His creatinine was 1. And then through the time, creatinine is 3. Today the creatinine is 3 and the bicarb is 24. So the poor guy, for 3 years, he's been doing Cosmos breathing. Imagine doing Cosmos breathing for like drowning for 3 years, and nobody caught it because nobody looks at the bicarb. You know, everybody looks at the PCO2, but nobody looks at the bicarb. In fact, they may have been happy that his PCO2 is going down. Oh my God, he's improving. His PCO2 is going. No, it's going down because he's compensating for bicarb and breathing fast all the time, day and night. So this way, when he gets a little bit tired, he comes to the hospital and we give him some Solomedrol and put him on BiPAP, and he does well. Right? So that you're gonna see that a lot. If you just keep an eye on this, you're gonna see it a lot, this condition. Okay. And the treatment obviously gives him bicarb. Any sort, PO, IV, anything, depending on how acute it is. But let me ask you a question. Remember when I said the story, I said the guy was wheezy. He was wheezy. So did he have COPD exacerbation? No. There's no way to have COPD exacerbation when your PCO2 is 40. Like, if you live at 60 and you come with a PCO2 of 40, you don't have COPD exacerbation. Guaranteed. You may be at the same level, 60 maybe, and breathing fast, that's COPD exacerbation. I agree. But to drop down your PCO2 and you tell me this is COPD exacerbation, it's impossible. Right? So why was he wheezy then? He was wheezy because of the Cosmos breathing. Because, you know, COPD is not like asthma. When it relieves exacerbation, there's still some obstruction. There's fixed obstruction and there's dynamic obstruction. So fixed obstruction, it's always there. You know, some swelling of the airway. But acutely, there's some, you know, acute exacerbation, so the obstruction gets worse. Huh? So in his situation, he is not in COPD. In fact, he probably is at his best time. You know, he's taking his medication, his lungs are in his best shape ever for him, because he could bring down his PCO2 to 40. Because bringing down his PCO2 from here to here is like you bringing down your PCO2 to 20. That's a lot of work. So for him, he could do that. So he's in the best place in his COPD, but he's wheezy because he's breathing fast. The flow against that fixed obstruction is too much. So that's why he's wheezy. Right? So don't be fooled by that. Right? There's a lot of thought that you can put into this, come up with the right diagnosis. You know, obviously, you know, you gotta be careful. You know, so you don't be cavalier about things, but at the same time, don't be fooled by things like this too. Which brings me to the stupid study that came 25 years ago or 20 something years ago when I was a resident. Came from the ER. And I think that's what sparked the ERs in general to do CTPA on everybody. Everybody comes in with respiratory distress, they do CTPA. Because the study showed that 25% of patients coming to the ER with COPD exacerbation were associated with PE. That's what the study reads. The conclusion is that 25% of patients who come to the ED from that study actually are associated with PE. So if you're an ER physician, 1/4, I'll be right 25% of the time. Just keep sending them. You know, it's easy for a CTPA, right? Also, the same study was repeated about maybe 6 years ago, and another similar study came out and showed 8%. Another, you know, so a different number, but it's a good significant percentage of patients presenting to the ED with acute exacerbation of COPD are actually due to PE. So when I was a resident, I was too scared to ask my attending because, like, I think I missed something in medical school. I need to go back and read because last time I checked, there's no connection between PE and COPD. Is there a connection between PE and COPD that I missed? There's no connection, right? They don't, pathophysiologically, they're two different diseases. Why does this have to be COPD exacerbation and PE at the same time? And I asked some of my colleagues and seniors and stuff like that, and they say, yeah, polycythemia, hyperviscosity, all of this bullshit. It's bullshit. What ended up happening if you actually, and then of course, when I grew up older, I looked into the study and found, basically, these two studies are database studies. So basically, they're looking at database. So the ER attending comes in, listen to the patient, who looks like a COPD patient. He has a history of COPD. Listen, he's wheezy. He's COPD exacerbation. Writes in his note, COPD exacerbation. Put the BiPAP on him and give him solibedrol, right? Then, down the line, he thinks, yeah, maybe, risk factors, blah, 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 blah. Let's send him for a CTPA. Or somebody else thinks of sending him to the CTPA. And then he finds that he has PE. Does anybody goes back and write COPD exacerbation ruled out? Nobody does that. We leave it in the note. It's not bothering anybody, right? And the coders have what, like photographic memory, ICD-9, they write it. So billing, this, all of them together. So when you look at database, you look like, oh yeah, they're associated 25% of the time. They're not associated 25%. This is totally different when the patient comes in with PE. He has a background of COPD, but he's coming in today with a PE, not COPD, right? Which brings me to another thing that I added to my practice to improve my detection rate, if you will, for patients with COPD. So you know the Wells criteria and all of these things and risk factors and all of this. But in order for me to decipher which patient coming from the ED to actually do the CTPA on, not every tachycardia, this is really embarrassing. Every time I see tachycardia, some people, oh, he's tachycardic, let's do a PE. You know how many conditions can give you tachycardia in ICU or PE? It's ridiculous. Anybody with respiratory distress is tachycardic. So that means if you think this way, everybody's gonna get a CTPA. So one of the things I add to the database data that you had collecting is the PCO2. Or the pH. So if somebody comes in COPD exacerbation with a low pH, comes in like this 7.28 PCO2 of 60. BiPAP, solibedrol, no CTPA. He's slam dunk COPD exacerbation. Of course, I could be wrong. I mean, some of them. That's why we need to apply all of those factors together. If he has any risk factors, please do the CTPA. Don't look. This is just one segment, one facet of the way you're thinking about them. But somebody like this 7.4, 80, coming in huffing and puffing, put them on BiPAP and solibedrol. That's the one that should get the CTPA. Why? Because this is his baseline. I know that this is his baseline. It's 7.4. So how is he in COPD exacerbation before the BiPAP? And add his baseline. It could be that he's just increasing his work of breathing, but I'm not going to take a chance because PE makes you breathe fast and makes normal people alkalotic. COPD patients cannot be alkalotic, so they are difficult for them to be alkalotic. So then we'll say, okay, that is a high possibility, we'll just add another number to the possibility of PE. Which brings me to the use of diamox.